صباح الخير. دقيقتين 3 ما نشوف حضور نستناهم شوية. Hope you all are enjoying the conference. I see many topics, many interesting topics, views from all the region coming together, experiences. Exchanging experience is just the best about these conferences. Thank you for organizing it and inviting us to this conference. Welcome everyone to Cochlear Symposium. For those of you I have not met before, my name is Nadia Abdelhaq. I'm an audiologist and speech pathologist. Have been representing Cochlear and working with Cochlear for the past 15 years in the Middle East and Africa. Today, I would like to take you through our innovations and a summary of how we focus on our patients, their outcomes, their lifelong experience with hearing, and looking forward to their best performance possible based on our technology. At Cochlear, we aim to empower people, professionals, parents, patients, families, all to hear and be heard. Through transforming the way we consider hearing loss, the way we treat hearing loss, and how we look forward to supporting all our patients. Through innovations and transforming the lives of patients and making hearing become an easier, lifelong performance. It is important for our patients to make sure that they are successful users of their cochlear implants and having a device that will help them throughout their life. We know that when managing hearing loss, for a lot of people, just having a cochlear implant makes a big change. But we have to also think about these people when they come to us for help, that they look forward to living the rest of their life with the best hearing possible. So when considering our patients, whether it is a 65, 75-year-old adult who just lost his hearing or had a few years of hearing loss, they have still quite a few years to go. More importantly, our population of children, which is the focus in our region, children are our main patients. They come to us at the age of 9, 12, 15 months, looking forward to living a full-fledged, successful life with hearing. So for all these patients, we need to make sure that we give them the best possible opportunity for lifelong hearing. Considering what are the benefits of hearing for these kids and how to make sure that they receive the best outcomes, there are individual factors that we know of and we cannot control. The period of hearing loss, the etiology of hearing loss, the degree of hearing loss, these are all things that come with the patient, and we take them into consideration when making our decisions. But then when delivering the solutions, there are some things in our choice of technology and techniques that we can use to help these patients for their best performance. So for Cochlear, we look at these issues starting from the surgery, the surgical procedures, the trainings for preparing for the surgery, looking at where is the best placement of the electrodes, which we know scala tympani is the best location for these electrodes to have the best outcomes in speech perception. Looking at the functional hearing of the patient, if there is any residual hearing, how important, how significant is it, and how can it help patient for best experiences. Looking at the placement closest to the modulus, again, to improve speech perception, to improve their hearing, and we're going to look at it in terms of structure preservation as well, because reducing the damage to the cochlea on the long run will ensure the continuity of best performance for our patients. In terms of the resolution of sounds, 22 electrodes are there to provide the best resolution possible of hearing. So a combination of all these factors can support the performance of our patients. And for cochlear, there are few unique factors that are only available from cochlear devices, looking forward to a lifelong of hearing performance. So let's start with where we are when a patient comes to us. There are a multiple of factors, mainly the most important ones that have been proven over and over with research. The age at implantation. We know the younger the better, even when it's a postlingual adult. Duration of hearing loss. The longer the duration of hearing loss, the less potential of good performance we have. The preliminary pure tone average, the level of hearing that the patient starts out with, is also a factor. And of course, preoperative aided performance and word recognition is another key factor. I want to focus a little bit on this last point. Looking at patients who have had hearing loss before they come to us for consultation about cochlear implant, research has again shown that patients who have had used hearing aids will perform better in speech perception than those patients who have not had hearing aids. So in a case where the patient has been having a progressive hearing loss and has used hearing aid, had some speech perception performance, post-implantation, we expect this patient to have better outcomes than a similar case who has not used hearing aids pre-operatively. So we do encourage the use of hearing aids, definitely, but once the hearing aids are not providing the patient enough sound to have good hearing performance, a cochlear implant should be considered, and the expectations are going to be explained. Now, let's move on to the next point, which is the scala tympani placement. Scala tympani is the location where we can be the closest to the spiral ganglions. Having an electrode sitting completely in the scala tympani is another reassurance that the patient will have the best hearing possible. This is a study by Scholl in 2018, where they looked at the performance of patients in terms of speech perception and looking at the placement of the electrode. You can see the first box bars, they show scala tympani placement where the performance is at its best. For patients who have scala vestibuli placement, those have performed significantly worse in speech perception. And for patients where the electrode is between scala tympani and scala vestibuli, they have the least performance amongst all. So again, confirming on the placement of the electrode in the scala tympani without having this transition to scala vestibuli or scala media is significant to ensure best hearing opportunity for the patients. At Cochlear, we have been working in our innovations to make sure that we introduce the electrode and insertion technique that would reassure the surgeon to have the placement in the scala tympani, proximity to the modulus, and making sure that the patient has an improved outcome with the best possible results. The slim modular electrode, the thinnest electrode out there with the proximal positioning to the modulus, giving the shape of the electrode, the natural shape of the cochlea, and closest placement to the neurons. And I'm going to go into that in a little bit more detail in a bit. The issue of hearing preservation comes up again and again. And Just last week, I had a patient come into my clinic. She has from moderate to profound hearing loss. She is a 5-year-old girl, and the parents are very reluctant to consider cochlear implants, fearing that she may lose whatever residual hearing she has in the low frequencies. Now, what is residual hearing? It is identified as the hearing with acoustical stimulation that is better than 80 dB. We know with cochlear implant there is a potential of losing some of that hearing. So a loss of 10 to 20 dB post-implantation is expected. The question is, how functional is that hearing at these low frequency? How much information does it provide the patient in order to hear and understand speech? So this is the main question we want to ask. Looking at the potential of having these cases among our patients, it is expected that about 10% of all CI candidates will have significant residual hearing that requires some preservation. And we do have to remember that the other factors still play a significant role in terms of the etiology, age at implantation, and preoperative levels of hearing, as well as the duration of hearing loss. But when we consider that, we need to think of the potential of losing further hearing and the fact that maybe once the implant is in place, the patient actually prefers to have electrical stimulation over a mix of electrical and acoustic stimulation. But for those patients where they have a higher potential of benefiting from having acoustic stimulation, we keep that in mind and we focus on preserving the structure of the cochlear implant because or the cochlea, because it will lead to the ability to hear with an acoustic component, and we can easily add it to the sound processor. So when you have a patient in this situation, consider, is it a significant factor? We will talk about it. We will put forward the potential, but our main purpose is to preserve the structure of the inner ear. So the questions that could be asked, does the patient have residual hearing in the low frequencies? What is the level? Is it considered as a functional hearing? Are we expecting to lose some of that functional hearing? To what extent? And will the patient benefit from electroacoustic stimulation? So these are just the consideration we need to discuss with our patients and their families. In terms of the preservation of the structure, we talked about placement in the scala tympani, and we want to make sure that we provide the best outcomes for a long time post-implantation. This starts with the proximal positioning of the electrode to the modulus. There are several studies out there that look at the performance with speech perception abilities in relation to the proximity of the electrode to the modulus. And we can see here in the gray dots and the results here, this is from a straight electrode, and the other dark dots are from a perimodular electrode placement. So in these two situations, we know, yes, we have to choose the electrode that best fits for the patient's needs, but also keep in mind the positioning. If I can choose a perimodular position, this will give me higher probability of best performance in terms of speech perception. What does that mean? Looking at this diagram, we see that the electrode that is at the lateral wall, the signal needs to travel a little bit further, and there could be more potential for overlap. While having a perimodular closer to the modulus positioning will reduce the distance, reduce the energy needed to reach the stimulation of the nerve, as well as reduce the potential overlap of the signal. In this study, Holden in 2013 looked again at the position in terms of the proximity to the modulus versus the outcome in terms of speech perception. And she found that the closer the electrode is wrapped around the modulus, the speech performance is better even after 24 months. So it persists for a longer time when it is closer to the modulus. This leads me back to talking about the preservation of the structure of the cochlea. So here, our ultimate goal is not to change the structure of the cochlea, not damage it, and not create something that will change its structure. What can cause any changes of the structure? Contact of the basilar membrane, elevation of the basilar membrane, puncturing it or scratching it, and the electrode placement that is closer to the scala vestibuli. All of these can result in some kind of reaction inside the cochlea. And here are some of the examples. Initially, we may have a hemostasis, but then we may have inflation, and we hope this subsides within a few weeks after implantation. Of course, it's a foreign body getting into the anatomy of the cochlea. But what we want to try and avoid as much as possible is the proliferation and the remodeling or restructuring of the cochlea. Now, what does that mean? In postmortem studies where they looked at cochleas and how the structure of the cochlea has changed from SAMDAS, they looked at the different structures that have been created where the blue is the fluid in the cochlea, the black spot, this is the electrode, but then we have tissue growth and we have bone growing around the electrode. So looking at the position of the electrode will also indicate where is the growth going to happen. In the far left picture, this is the electrode close to the modulus, and the tissue is expected to grow around it and also some bony structure. But the distance or the proximity to the target of stimulation, which is the auditory nerve and the spiral ganglion, is right here. So we have very little change in this area versus a lateral wall electrode that could have also tissue and bony growth around it, but then it becomes a barrier between the electrode and the target, which is the spiral ganglion. So the signal, the electrical stimulation, needs to travel through tissue, which creates higher impedances, and we need to shift the levels of stimulation, and then battery consumption becomes higher. This is another study where they look at how much the structure can be affected on the long term. And they found that in, again, post-mortem study, that the tissue growth around the cochlear implant, it has a negative effect on the speech perception ability of the patient. So when we see changes in the performance of the patient over time, we need to consider this could be caused by growing tissue around the electrode. Now, we know for sure, post-meningitic patients, we've seen this, that we have new bone growing and electrodes going out of compliance and having to be shut down. This is an extreme case where we know it is bony growth. But when, again, thinking about children who are now 1 year, 1.5 year olds, and we want them to hear for the next 80 years, then this point needs to be taken into consideration. So looking again, starting from the placement, we want to make sure that we have the electrode sitting in the scala tympani. We want to preserve the structure by having this assurance. We want to look at even though it's just a 10% of our patients that may have functional hearing that needs to be preserved, and they will be using it afterwards. But again, structural preservation becomes important here. Proximity to the modulus, it provides better outcomes in terms of speech perception, but it also provides better performance even if any structural change may happen in the cochlea. And having this low incidence of injury inside the cochlea by not putting any pressure on the lateral wall, not coming close to the basilar membrane, or the potential of going through the basilar membrane into the scala media or scala vestibuli, is another more effective way of preserving the structure of the cochlea. How would we achieve that? This is by providing the design of the electrode that is the slimmest and most closely positioned to the modulus. This electrode provides 22 independent electrodes that provide stimulation to the stimulation to the spiral ganglia by being positioned closely to the modulus. This close proximity has shown that it provides up to 30% greater success in performance than slim electrode, straight electrode. And having more independent electrodes provides higher resolution in terms of the signal of speech. So looking again at these components or building blocks of success for our patients, we see that there are multiple steps that can be taken into consideration: preserving the health of the cochlea, making sure that we are giving the patient the best chance possible at best performance. And there are a few of those that are unique to cochlear. So the proximal positioning, reducing the injury inside the cochlea, and the independent 22 electrodes, these are specific to the electrode design from Cochlear. And this is in the form of the slim modular electrode that comes with a flexible sheath, allowing the surgeon to perform a round window insertion, making sure that the placement is in the scala tympani, close to the modulus, and with all the factors that we have discussed so far, hoping that this will give our patient the best chance for a lifelong performance. Thank you for your attention, and questions are welcome. Dr. Aziz, yes. Would we have a microphone? Where's the audio people? I'll come to you. أهلا دكتور. ازيك؟ Good.
Can I histopathologically the spiral ganglia, the modulus, doesn't reach the apex.
Right.
I want to hear your comments on that the deeper we get into the cochlea, the better results. Why is that?
Well, I cannot answer for those who put this argument forward. Our belief at Cochlear is the target stimulation is the spiral ganglion. As you have mentioned, and as many research has shown, that the spiral ganglion does not reach the apex. So our aim is to have an insertion of 400 to 450 degrees that allows of a maximum coverage for the spiral ganglion. And so far, with this slim electrode that is wrapped around the modulus, this provides a good depth that allows for full coverage of the spiral ganglion for sure. And I always think of it when I'm driving. You know how in the driving routes for Formula One, for example, you take the curve, you want to go faster, you take the inner side of the curve because then the distance becomes shorter. If you take the outer side of the curve, you take longer distance, then you need to travel longer. So for me, the cochlea, the inside, the modulus curve is the shortest. So with the length that of electrode that we have, we do reach the insertion of covering the target spiral ganglions. Thank you. Yes?
Thanks for nice presentation. Any company have a certain recommendation in soft cochlear implant surgery. As a guard cochlear company, any recommendation in cochlear implant soft surgery technique,
Yes.
like time of insertion, even the direction, or any difficulty during insertion?
Yes. So since we have introduced the pre-curved electrode with the contour advance, we have used a technique where it is off stylet, advance off stylet technique, which means you insert the electrode, but then you hold the stylet and you push off the electrode. And if you watch on the screen in our insertion model, you can see that the tip of the electrode does not reach the lateral wall. It immediately starts curving and hugs the modulus. So this is the least traumatic approach. With the our electrode, that is the slim modulus electrode, we have replaced the stylet with this sheath, which keeps the electrode straight, allows the entry through the round window, and positioning in the scala tympani, and then again hold the sheath steady and push the electrode in. Immediately, the tip starts to fold and hug the modulus, and this also has an atraumatic insertion. Yes, sir.
Okay. Thank you for your nice presentation. I am Dr. Mugad, the phoniatrician. So my question is related to my specialty. As we know, the younger the age, the better the prognosis for CI.
Yes.
So I am asking, what is the exact age if we have a child, prelingual, that's congenital hearing loss, prelingual, and he is non-verbal? What is the exact age that we can say after that age he will not take benefit of CI?
All right. So considering, yes, we keep saying younger is better, and there are countries that have the surgery as young as 6 months, depending on the health of the child. When we talk about the benefit and how long can we wait, or if the child comes to us at age 3, 4, 5 years, should we recommend a cochlear implant or not? This is all related to the stimulability and ability of the brain to create the neural connections to have and create this knowledge of listening and therefore learning language. We know that up to the age of 5 years, 90% of the structure or the basic connections in the brain have been created. And after that, we build on that initial connection that has been created. And the whole development of the brain slows down after that. If you want to look more into details, into more specifics, there's Anu Sharma. She's a neurologist, audiologist, and she has been looking at the brain function in relation to hearing loss and how that can be improved. And she has shown in her study that, yes, it does slow down. And here the question is not whether to recommend or not to recommend a cochlear implant. It is rather about the expectations, setting realistic expectations. So a child at the age of 5 who has nonverbal, prelingually deaf, and has no other disability, so cognitively, behaviorally, physically, everything, is just has only hearing loss, we expect this child to be able to hear, learn to distinguish sounds and words and sentences. Will the child be able to develop language to the point of having age appropriate language level? Probably not. Will the child have enough language to attend school? Maybe, but will always have a learning disability. So I would not go and say, don't implant, but I would discuss the outcomes expected post-implant for that child. Thank you. Dr. Muhammad Fargal.
Thank you for the nice presentation. I have a comment rather than a question. I have the experience with the lateral wall electrode from cochlear, and we have the experience with the perimodular stem electrode. So I share with you the insight I got from a good number of patients.
Okay.
So the stimulation levels with the perimodular one is much less. Out of compliant issues is very rare, and facial stimulation. It does not occur with the perimodular. So dramatically, really, from a solid experience, the performance with the perimodular is much, much, much better than the lateral. Thank you.
Thank you. So if Dr. Fargal's comment was about the potential of facial stimulation is reduced with the perimodular electrode, and the performance is definitely better with the perimodular electrode from his own experience with his patient in his clinic. Thank you very much for your insights, and I hope you enjoyed it. I will be around at the booth. We also have at the booth the Smart Nav, which is our latest intraoperative measurement, and commenting again about the speed of insertion. We know the slower the insertion, the better the outcome. There's no specific recommendation for it, but our Smart Nav does provide the ability to monitor the speed of insertion during the implantation. And also for our audiologist, we also have the remote check function, which is a part of the Smart app that will facilitate your support for your patients. Knowing Egypt, how big it is and how busy the streets are, I think that would be something to look into for better supporting your patients. Thank you very much, and see you at the booth. I think we have a long break now for prayer and lunch, and I believe we come back around 2.